Good morning, everyone. My name is Sandeep Basavarajaiah. I'm a consultant cardiologist based in Birmingham, in England. I work in a hospital called Heartland Hospital. It's a great pleasure to be part of this very prestigious symposium, NIC in Hyderabad, and I'm very honored to be invited here as an international faculty. So my area of specialty or interest is chronic total occlusion angioplasty. I'm also one of the world experts in drug-coated balloon angioplasty in coronary intervention, and also undertake a lot of complex chip cases in calcified lesions. So my focus for this 3 days in meeting is on drug-coated balloons, where we are expanding the use of DCB in not only restenotic lesions, where there's a well-established indication and guidelines, but for de novo lesions, especially small vessels, long lesions, because in the current era, we should be aiming to put less metal as much as possible in these coronaries. Because if you do place a stent in a long lesion, diffuse disease, small vessels, in a patient who are diabetic, renal failure, bound to have restenosis over time. And once you have restenosis, they're very difficult to treat. No matter what you do, they keep coming back with the high rates of recurrence. So in these patients, we should be using drug-coated balloon, which is now making a big comeback in the international arena. And we have large experience because where I work in Birmingham, we serve a large number of Asian population with diabetes, and we're a big renal center. And we're also a big center for oncology, so we have a lot of high bleeding risk patients. So we tend to use more DCB. Almost 40% of our cases are treated with DCB. Sometimes we use this hybrid strategy where we stent the proximal arteries, which are over 3 millimeter, and anything 3 or less, we use drug-coated balloons. And there are a lot of trials coming on, and we are very proud to be part of it. We use both paclitaxel and sirolimus balloons in our practice, and we have had some excellent positive remodeling on the follow-up angiography. The next area of interest, of course, is CTO angioplasty, which obviously again is one of the growing and expanding field as we got more expertise and more kits available. And again, CTO angioplasty, of course, has to be undertaken in patients who needs it, but we have to justify with either ischemia viability before we embark such complex procedure, as they are complex and can result in complications. And of course, with the invent of new tools and kits, the retrograde angioplasty has progressed quite a lot. And we are one of the big centers in the UK to undertake CTO angioplasty. And finally, the calcium, of course, you go to any meeting these days, there's a session on calcium. Everyone loves calcium. Yes, calcium is the big frontier to crack, and we now are very privileged to have specialized tools such as shockwave balloon, rotational atherectomy, diamondback burr, and of course we have these cutting balloon and scoring balloons. The most important part of calcium management is the imaging. This is something which we have to keep in mind. You have to do upfront imaging so that you know what you're dealing with. And not only just upfront imaging, you have to keep imaging at every stage after you do a modification technique to check that you have done the right thing before placing the stent. If you go back 7-8 years ago, the IVUS or the intravascular imaging was only undertaken before the stent deployment or maybe after stent deployment to optimize. Maybe that's too late. But now we are learning to do upfront imaging. And yes, it can take a bit longer to finish the procedure, but if you develop this routine and habit, it becomes a normal routine in the cath lab, and it certainly gives you a better result, especially in the long term. So these are my 3 areas of interest which I have alluded to, and it's a great meeting, and I'm looking forward to some very interesting sessions. I've just come back from a calcium session, and I've got a session on DCB tomorrow. And I would like you all to enjoy this meeting, and I would like to thank the organizer, Dr. Pratap Kumar, for arranging this meeting and inviting me for this. Thank you.